were excellent results. Next, I would like to invite Dr. SANTOSH HONAVAR, who needs no introduction, for his talk on orbital retinoblastoma. I think he is amongst one of the few people in the world who's got the maximum experience in retinoblastoma, and so he has developed the multimodal therapy for orbital retinoblastoma that has actually changed the treatment protocol throughout the world for managing these advanced cases.
Switch. Okay. Good afternoon. I'll be talking about orbital retinoblastoma, just to mop up the retinoblastoma instruction course. You don't see it very commonly, but when you see it, it's kind of a terrifying situation because it has a very difficult way of managing it, and children go through a very bad phase during the management. So definition is that when a tumor is found outside the confines of the eye, which could mean that it could be frank orbital, it could also mean that it could be optic nerve extension and full thickness scleral extension. Even that is considered orbital retinoblastoma. Of course, it's the minimal variant. Incidence is hugely variable. In India, we have 6 to 30% depending on which part of the country you are looking at. In Mexico, Taiwan, Nepal, Africa, you see the incidence. Africa probably is the highest, 30 to 60% of children there present primarily with the orbital retinoblastoma. These are some of the known facts about orbital RB. It manifests in older children. You don't see infants with orbital RB because it takes time to grow. Mean age is about 3 years. Most of them are unilateral. Unilateral retinoblastoma is often missed. Bilateral, because of poor visual responses, parents may take the child to a pediatrician or an ophthalmologist, whereas unilateral, because the other eye being normal, children may keep seeing well until the retinoblastoma is advanced, and that breaks out into orbital RB. Or obvious proptosis like this without inflammation. So if you see proptosis with flat lids without lid edema, most likely it is orbital RB. But if you see proptosis with lid edema, it could be sterile orbital cellulitis causing proptosis, and that you must differentiate. In a secondary situation, when you have already done enucleation, if a prosthesis were to be fitting properly earlier and suddenly now it becomes displaced, or the implant gets displaced suddenly, that's an indication that there is some growth in the orbit, and that generally is secondary retinoblastoma. You must differentiate whenever you get a child with proptosis, sterile orbital inflammation. It will have conjunctival congestion and lid edema accompanying leukocoria, as you see there. And when you do scan, you don't see a mass, but diffuse inflammation periocular, and that may even extend to the orbit. Sometimes it may hide a subtle orbital extension. So after giving steroids to these children, you have to repeat the scan to see if there is any scleral nodule, which may be hidden by the initial inflammation. So you have to repeat scans twice in such patients. There are many classifications of orbital RB. This is children cancer group classification, which is no longer used. What is used is international staging system for retinoblastoma, where orbital RB is stage 3. Regional extension with overt orbital disease is stage 3A. That's where it fits in. And in AJCC 8 classification, it is CT4. Now, there are 5 variants of orbital RB. Morphological classification: primary, when a child who has not undergone any treatment earlier presents with orbital retinoblastoma. Secondary, this is how it may present: primary orbital RB, or sometimes you may not see it clinically. There may not be any proptosis, or there may be very mild proptosis, but when you do scan, you may able to see an orbital extension. So either it is diagnosed clinically like this, or on radiology or MRI. Now secondary is when you have already done an enucleation and the child presents with an orbital mass. So enucleation, to prevent it, enucleation has to be performed without accidental perforation. Sometimes when you do enucleation, if you are slightly rough with it, there might be a scleral perforation which will spill the tumor into the orbit. And you should always go for the longest possible optic nerve stump. Anything which is about 15 to 20 millimeter is ideal. Example is this patient where you see optic nerve is thickened here. That means it's involved. If you were to go by the textbook description of 10 millimeter stump, you would still be left with tumor at the transection edge, and that will grow into a secondary orbital retinoblastoma. So you should always go for the longest possible optic nerve stump. Anything less than 15 millimeter, I would consider suboptimal. Let's skip the video. Now, accidental is when somebody does an intraocular surgery for an unknown retinoblastoma. This child actually presented with hyphema with a history of trauma earlier, and somebody did a hyphema drainage and did a trabeculectomy, and few months later child presented with a subconjunctival mass, and in addition there is, you can see, regional lymph node extension. So this is accidental when somebody does cataract surgery with conjunctival flap, or a trabeculectomy, or a retinal reattachment surgery, or vitrectomy for a child with retinoblastoma without realizing the child has retinoblastoma. Overt is when you clinically, radiologically are unable to detect it. A small scleral nodule may get missed on an MRI. Clinically, of course, there will not be any proptosis, but on enucleation, you find that there is actually extraocular extension or optic nerve involvement. This patient has both scleral nodule as well as the optic nerve involvement, because optic nerve is standing stiff like that. Optic nerve has to be very flexible and fall flaccid when you enucleate. If it's standing stiff like this, that means that there is optic nerve involvement. Microscopic is when everything else is undetectable, like radiologically, clinically, you're not able to detect orbital RB, but on microscopy, histopathology, pathologist is able to tell you that optic nerve transection is involved, and you can see here, this is choroidal involvement, this is sclera, and this is extrascleral extension, a flat placoid extrascleral extension. That's again orbital RB, that's microscopic. So microscopic is when the transection is involved or there is extrascleral extension. Now, conventionally, orbital RB was managed with orbital exentration, chemotherapy, and radiation, either one or two or three modalities in a very haphazard kind of a combination. It had poor prognosis with 70 to 100% mortality. Now, why do we need to combine all three modalities in a very logical sequence? That is because each one works differently, and all put together will benefit the child. Chemotherapy reduces the tumor burden. It also takes care of microscopic metastasis. Radiation makes sure that the tumor does not come back in the orbit. Surgery is essential to enucleate. You don't exenterate generally. So you always start with neoadjuvant chemotherapy, which is high dose or adjusted standard dose towards high dose. So when you do that, the tumor shrinks very rapidly. Orbital retinoblastoma shrinks very rapidly with chemotherapy. And once on radiology you find that the orbital component has completely resolved, then you would do surgery. Surgery could be enucleation, extended enucleation, and extremely rarely do you have to do orbital exenteration. Once that is done, the entire area where the tumor was earlier is treated with a well-planned stereotactic radiation. It's important to not to undertreat and include the entire area where the tumor was located pre-chemo. So you base your radiation portal based on the pre-treatment extent of the tumor and continue high-dose chemotherapy for 12 cycles. So if you, for example, if you start with chemo and then do surgery at say 5 cycles of chemo, you have to continue 7 more cycles of chemo. So total is 12 cycles. That is how it goes. Now, doses are given here. I won't expand on that, but carboplatin, etoposide, and vincristine are the standard workhorse drugs. For secondary orbital retinoblastoma, generally we don't have to do surgery because it resolves very beautifully with chemotherapy and radiation alone. But if there is any residual tumor, you perform surgery, which has to be orbital exenteration. Accidental orbital retinoblastoma, if it's just a minor spillover, say somebody has just done a SICS with a small conjunctival peritomy, then you can do en bloc excision of the eye, including the area where conjunctival flap had been earlier made. So that's a very minor variant of orbital RB accidental. But if somebody has done a 3-port pars plana vitrectomy with a large gauge instruments and spilled over in the entire orbit, then you begin with neoadjuvant chemotherapy, then do enucleation, and the whole works like that. Now, overt orbital retinoblastoma, standard is to give external beam radiation and adjuvant radiation. Microscopic, generally if it is microscopic RB, it is treated with EBRT followed by adjuvant chemotherapy. Now, these are some of the examples of patient where despite chemotherapy for neoadjuvant mode, there is viable tumor. That is the reason why you have to continue treating these children. Some of the case examples. This child was brought with orbital RB, that is the orbital extent, and he had this kind of an appearance. You can even see an anterior scleral nodule, that is the scleral nodule. Following neoadjuvant chemotherapy, you can see eye has gone into a very comfortable phthisis. And at that point, you would do a enucleation with a long optic nerve stem. There is no role for doing orbital exentration. Then there was radiation and then adjuvant chemo. This child, you can see, was very uncomfortable. After one cycle of chemotherapy, the tumor has reduced to the extent that we were able to pull the lids over and do a tarsorrhaphy. So child becomes very comfortable and eye has gone into phthisis. Then you would enucleate. This child also, you can see, eye has shrunken into a very gross phthisis. That's exactly the time when you enucleate. So radiologically also you have to confirm that the extraocular component has resolved. These were earlier considered untreatable, like patients who had cavernous sinus involvement. They were considered untreatable. They were only given palliative treatment. Now they are treatable because you can see that after neoadjuvant chemotherapy, all that is left is at the superior orbital fissure, which can easily be radiated. Of course, the child did need enucleation. Now, how beautifully optic nerve component resolves is seen in this picture. You can see thick optic nerve pre-treatment. Following neoadjuvant chemotherapy, optic nerve caliber has become normal. Then you would do a enucleation with a long optic nerve stump and go ahead with the rest of the treatment. Cosmesis is assured if you are if you're not planning to do orbital exentration. This is a child following completion of treatment. She can wear a nice prosthesis. One more child, you can see her eye went into a beautiful phthisis. And then we could do enucleation despite radiation, which is well planned. She has a reasonable amount of cosmesis with a custom ocular prosthesis. This is a secondary orbital retinoblastoma treated, and the child is now able to wear up. Earlier, these were all exenterated with very limited cosmesis. This is the only patient that I have done in the last several years where orbital exentration was required, because despite 12 cycles of chemo, child still had residual orbital RB. Treatment complications are mainly related to chemotherapy and radiation. There is more than 95% survival in orbital RB if you actually treat them with multimodal treatment. So I would conclude saying that orbital RB is difficult to treat, but if you plan your treatment carefully, starting with neoadjuvant treatment, do surgery which is minimalistic surgery, not exentration, at an appropriate time, and then follow it up with radiation and adjuvant chemotherapy, these children do have a chance of survival as good as any other child with retinoblastoma. Thank you so much.
Thank you, sir. The newer treatment modalities have really altered the way these cases were managed, and the survival has drastically improved. So, have you seen some difference between patients who got just optic nerve involvement, whereas orbital involvement? Is one group faring better than the other?
They're not really faring better. Ultimately, they all settle down in the same way. Optic nerve extension actually has a very, I would say, slow response to chemotherapy, whereas orbital RB melts with chemotherapy. So in optic nerve extension, although the response to chemotherapy is slow, you're not treating that by doing chemotherapy. You're also treating micrometastasis. So that way you're successful. Anyway, you have to do, enucleation and then radiation as well.